Okay, everybody. So sometimes I jump on here on the weekends and just answer a couple questions. Again, I don't give any formal medical advice, but I love to kind of go over different topics. So let me just get questions coming in. I'll open the comment box. Again, my background is I am a spine surgeon here in Dallas, Texas. This is my hometown. It's the same city I was born and raised in. And the way I like to start off these things is just kind of giving a little background information on spine questions, spine surgery. And then from there, I can kind of get into the nitty gritty about different conditions you might have heard of. Again, I appreciate all the comments and supports coming in. I'll try to get to them as best as I can. So look, the number one question I kind of get asked, and I don't know if us as spine surgeons do a great job of describing, is what is arthritis in the spine? And a lot of people, when I'm talking to them, I maybe casually mention, oh, that you have a little bit of arthritis here and there, and they're shocked. They're like, I have arthritis. Like, oh my gosh, I heard my mother had arthritis. My cousin had arthritis. I can't believe I have arthritis. Well, let me be a little more clear and a little more informal in terms of what I mean when I say you have arthritis in the spine. So in general, there's a lot of different types of arthritis. You can have rheumatoid arthritis. You can have septic and infection arthritis. The arthritis that I'm referring to, and probably your spine surgeon, if you've heard them say that, is referring to, is the type of arthritis where it's a degenerative arthritis. Just like when you lift weights or work out or work in the house or pretty much just do something in life where you get a callus formation on your hand, that's kind of arthritis. I would think of arthritis as your body adding extra tissue to protect itself. So appreciate the likes coming in. That really helps this. So if your body is adding extra tissue to protect itself, just like a callus formation, because you have a lot of wear and tear going through here or on your feet, and your body's like, hey, I don't want it to wear away, so I'm going to add extra tissue there. Think of arthritis as that. Okay, so now in the spine, if you have certain inappropriate motion, or you just have a lot of wear and tear through the spine, through your job, through your life, through genetics, you can get arthritis in the spine. And that sounds terrible, but everyone in a way has arthritis through the spine. Everyone, if I got an x-ray on, pretty much anyone over 40, there's going to be some degenerative changes here and there because our bodies, they get older. It's like a car engine. There's things that wear out every now and then. So when I'm talking about arthritis, here are the things I'm really focusing on. Here's the side view of the lumbar spine. So if you're walking in, it goes bone, disc, all the way down. You can get arthritis in the disc space. So it kind of decreases a little. But the most common thing I see, both on x-ray, CT, MRI, are these facet joints in the back. So these are the joints that move back and forth in the back. If you get arthritis in the facet joints, they can grow extra tissue. And they grow in the back here in the muscle, no big deal, that's fine. If it starts growing into the nerves, then that can start pinching the nerves. So arthritis in the back can be some medical word called arthropathy, degenerative changes, thickened facets. These thickened facets, degenerative changes, start squeezing the nerves, causes numbness and tingling, pain, and weakness. So in general, when I tell a patient they have arthritis in the spine, they shouldn't be blown away. Everyone has a little arthritis in the spine. That's just kind of a key part in terms of going over different spine care. So I'm going to kind of rip through a couple questions here. Richard, thanks for your comment earlier on YouTube. That really helped me on a couple things. From, how do I say that name? Shynomics. Am I saying that right? Shynomics. What's the best option for a pars defect? Well, you don't necessarily need surgery just because you have a pars defect. But if it is debilitating pain, if you failed non-operative treatments, a pars fracture, that's what this model has. So when this bone is kind of wiggling, your facets aren't really connected, your joints aren't really connected. That's usually from there's 6 types, but usually it's from a hyper extension injury where you've had micro traumas, real trauma. It creates a little fracture of this bone here in the pars. And then once you lose that 360-degree tension band in a way, like you have a tension band in the front, you have a tension band in the back, that then puts accelerated stress on the disc spaces, and then it starts to kind of squeeze down, wear out that disc space. Then it can start pinching that nerve. Anyway, these are all kind of it's not just the pars fracture that's the issue, it's the symptoms associated with the pars fracture, if that somewhat answers the background of your question. In terms of what's the best option, there's not a huge debate on this. This is something that was really kind of teased out in the early 90s, early 2000s. Headland and Moeller Moller, have some great papers on it from like 2000, 2005. And they really looked at if you have pars fractures and you have pars fractures and spondylolisthesis, what's the best options in terms of fusion, non-fusion, something called in situ fusion, open decompression, and no fusion. There's a whole realm of papers there. One of the papers in 2006 won Best Paper Award. Is from Carnegie, I think, at Stanford. What I'm getting at is fractures need fusion. There's been multiple peer-reviewed studies, and these have been replicated, and now it's not even a debate, where if you have a pars fracture that has failed conservative treatment options, the gold standard is to fix that fracture. Then there starts to get debate about, well, what does fix mean? And it fixes fusion. But in terms of, sorry, I'm grabbing some spine models over here. In terms of, do you need to have screws in the back, or can you just use the patient's fragment there and just grind up that fragment and put it on the side? That's an option, but it's been shown in the pedicle screw error. So what we've been in for the last 2 or 3 decades, kind of 2 plus decades, these pedicle screws are the gold standard for that type of diagnosis because it stabilizes the area. Then there's a debate on, do you need a cage in the disc space? The majority of spine surgeons would agree you do need a cage in the disc space. It increases several factors. It increases your fusion rate. That's not even debated. Gives you the height back. It opens up the nerve tunnels. And then in terms of where to put that cage, do you go through the front, through the side, through the back? That's something that is debated. I usually say whatever's best for that surgeon is maybe, hopefully, best for that patient. I like at L5S1, that lowest level, going through the belly, putting in one of these spacers. That's a big part in terms of better height restoration, foraminal height, the nerve tunnels, curvature, higher fusion rates. There's even great studies by someone I really respect named Dr. Andrew Simpson that show that when you go through the belly as opposed to all from the back, you have higher patient-reported outcomes, higher fusion rates. Either way, I think just knowing your diagnosis is good. And then on top of knowing your diagnosis, kind of knowing that there are treatment options out there. So I know those are very long answers, sir. Shynomics, am I saying that right? Shynomics, I think I'm saying that right. But that's kind of your answer. What's the best option for a pars defect? Kind of depends on where you're at in that scheme of things. Not everyone's going to need surgery for it, but that's what I'd recommend. So to reset, I see some questions kind of coming in. To reset, I am a spine surgeon here in Dallas, Texas. I do everything from the skull down to the pelvis. I don't really want to talk about marketing or insurance stuff. That's not really what I'm doing. I'm trying to just rip out a couple questions here. From Gordo, I had surgery in March. Now pain rushes to my head when I lay on my back. I'm not exactly sure what that would be from. From Crystal, please walk me through everything on ACDF. I've been scheduled and am very nervous. Sounds good. Let me see where my spine model is. I probably should not keep these right behind me. Okay, so here's an ACDF. In general, an ACDF is a condition to treat degenerative disc disease in the neck, disc herniations, spinal stenosis, that's squeezed nerve, spinal cord damage. Here's a model of a 2-level ACDF. And it really is a great surgery. It's still considered the gold standard, what we measure everything on, because it's so tried and true and patients do so well. In a nutshell, it's a small incision. So if this is a writing utensil, I'd say it's about the size of that black part. It also depends on how many levels and how the surgeon wants to do it. But I want to say mine's probably about the size of that black part of the pin, is usually I tell patients. It can be off to the left or the right side of the patient's neck. There's no difference in the long outcomes in terms of left versus right. And then once you go down through that left or right side, you push the esophagus and the trachea to the side. That creates something called dysphagia, a little difficulty swallowing foods, a little hoarseness in your throat afterwards because you're pushing that to the side. You get to this front part of the spine here, clean out the disc space. You could put pins in it to open it up, kind of like a car jack. Clean out the spinal cord issue in the back, and you put it in a spacer. In terms of what the spacer is, you have 3 options, or the spine surgeon has 3 options. You can do cadaver bone. Great. We did that for years. You could do something called PEEK. It's kind of a medical grade plastic, or you can use titanium, or you can use now PEEK coated titanium peak coated in titanium is also an option. They're all great for different things. I'm not going to poo poo one versus the other. I think first generation peak is no longer as accepted, but there's better peaks out there. Not to get too lost in the weeds there. I like titanium. I think it's great. There's certain insurance carriers, mainly Aetna, the devil, and sometimes Cigna, that actually only allow the surgeon unless certain things are met to use. Let me say that differently. Aetna requires me to use cadaver bone unless it's next to a prior fusion or unless I'm doing something called a corpectomy. They want me to use dead cadaver bone. And that's fine, but I have a lot of patients who are like, well, I don't really want dead cadaver person. That's usually someone's fibula. So it's some guy or girl's fibula in my neck. I'd rather have some of the more high tech stuff. Well, tough for you. The insurance companies make about $6 billion a year and they don't care what you think. And I am being pretty openly critical because they stink and we all deserve better. So let me kind of jump to a couple of questions here and we'll get to that. So Deborah, hello from Northeast Texas. I have spinal stenosis and osteoporosis. Okay, sorry to hear that. And you have, looks like chronic fractures. Sounds great. From Desiree, hi from Australia. Great. So I'm just reading these as they come in. What's your opinion of laser surgery to treat chronic pain and inflammation? Kind of in short, there's no such thing as laser spine surgery. There's actually publications in one of our highest journals called the Yellow Journal or Journal of Orthopedic Association. JAOS is what it is. And it's Chris Kepler, Schroeder. I think Dr. Vaccaro's on that. And they kind of say, it's a marketing term. Pretty much it's just, it's something, it's like a probe with a hot probe on the end of it and it's just burning it. So someone could call that a laser, I guess, in the textbook of definitions, maybe that is a laser. But and laser spine surgery is kind of a marketing thing. It's really just burning something. It's just a probe. So I just want to make sure people are clear on that. And they're not seeking out something that maybe they can get across the street. The other thing I really just want to emphasize is you might be talking about an ablation, an RFA. I don't do those, but I highly support them. So if that's what you're talking about, a laser for an ablation, ablations are great for chronic back pain, and those are still a great way to take care of that. So maybe that's what you're referring to. From Donald, which is best for L5, L4, a TLIF or an ALIF? Donald, really that's based on surgeon's preference at 4-5. So there's some people that I'm gonna hit something here. There's some people that won't be able to get an ALIF at 4-5 just because their vascular surgeons aren't confident at that level. And like here in Dallas, we have vascular surgeons. They legitimately would do it at L1, L2. They're so skilled and so good. It's not an issue, but certain communities don't have that type of privilege, and no problem at all there for that. We'll just decline that. From Mama Chow, are SI fusions worth it? Yes, but only if done with a spine surgeon. I think only a spine surgeon should be doing spine surgery. I think pain management doctors are great and they have an exceptional role in society, but I'm a big fan of spine surgeon doing spine surgery. If you agree with me, go ahead and hammer the likes there. Let's try to get that up to 10,000 likes and let's just keep hammering that away. So SI joint fusions are worth it, but they're good when you prove that that's your diagnosis. Jumping back to this one, scheduling a laminectomy soon. Any exercises to strengthen my back before the procedures? I'd focus in terms, I'd do planks, almost like when you get up in a push-up position. Planks are a really great exercise to strengthen your back. And then I'd focus on hamstring strengthening. Do you know of stenosis causing burning mouth syndrome? From Sherry? No, I don't exactly. I mean, I don't understand all those words mean, but I don't know what burning mouth syndrome is. I really don't think stenosis would cause that. I've never heard of that. But again, I don't exactly know what that diagnosis is. From Wanda Lee, I don't have an answer for you on that question. From Azura, I've had good pain relief from nerve ablation. What do you think? I think that's great. Surgery for Parson-Turner syndrome. That's not a surgery I do. More of like an upper extremity surgeon does those. From Ann Rohan, I have severe stenosis, 4551, pain down the leg night, but causes to have severe claudication. My doctor is reluctant to do surgery. I'd like a second opinion. Interesting. I'd be interested to know why you say the word claudication. That's a very specific spine surgery word, like neurogenic claudication. So how do you know you have claudication? That's a very upper level spine surgery word. And so if someone's telling you have claudication, that is definitely a surgical indication, not like an emergency, but it's a surgical indication. So if you're saying your doctor is reluctant, just something doesn't add up. How would you know you have claudication unless a spine surgeon told you? And then why would they not want to do surgery? So I don't have an answer for you, but yep, always happy to take a look. How do I feel about spinal cord stimulators? Mixed feelings. I really think spinal cord stimulators are best for people that have back pain that we don't have a great answer for in terms of why they're having back pain, or they're reluctant, understandably, for sure, understandably, to have a big old spine surgery for their back pain. It's not a great fix for shooting down numbness or tingling down the legs because usually, and again, this is all broad generalization. I'm not right about this. Usually, pinched nerves shoot down the leg. And if that's the issue, you should just get that pinched nerve fix. The spinal cord stimulators are kind of a different thing. That's from either when you have spine surgery and it never really took care of your pain completely, and that sucks, and we really don't like that. But also that could be maybe your balance, your spinal is in a poor balance, and that's why maybe again, maybe you're morbidly obese, maybe you have severe joint arthritis, and there's just other things going on. A little hard to say. So I'm not against spinal cord stimulators. I think maybe once a year I order them for my patient, or I send them to a pain doctor I trust to get evaluated. But I would say it's not infrequent that I send a patient to a pain doctor to get like an injection and they get offered a spinal cord stimulator. And I'm like, no way. That blows my mind. So that shouldn't be the case. If you have a complete disc replacement, how long do they last with the new technology? And is there recurring surgeries required for the surrounding joints? All right, let's talk about it. So I think y'all should think about disc replacements similar to hip and knee replacements. For the neck and the lumbar spine, they're totally different. The neck and the lumbar spine are totally different, just like a hip replacement is kind of totally different than a knee replacement. So putting a hip replacement and a knee replacement in the same category, once you start getting into it, is not, they're totally different implants, different companies, different anatomy, different surgeries. They're totally different just because they're a replacement of a joint. Like you could do a replacement of the ankle joint, but that is totally different than a hip joint. So with that being said, I encourage patients to really focus on the neck replacements and the lumbar lower back replacements as two totally different things. Okay, so that being said, I am 2 thumbs up for cervical neck disc replacements. They have an extraordinarily good track record. We've been doing them here in America since at least like 2002. Different types have come and gone, and a lot of them have stayed, and we've perfected the ones we've stayed. Some of the best data we have is in a 2020 study in neurospine. They looked at 2 level and 1 level, but also 2